Hello, everyone. Our topic today is about prognostication in the palliative care setting. Um, During this presentation, we'll be talking about, what is the definition of prognostication? What do the patient want to know? Reviewing prognosis for terminally ill patients, reviewing difficulties of prognosis, and review how to convey the prognosis, or in other words, breaking bad news. So, prognostication is a prediction of possible future outcomes of a treatment or a disease course based on medical knowledge and experience. The Arabic word for prognosis is takahum. Uh, do the patients really want to know? So there's been a poll in patients with serious illnesses. 55% of patients wanted to know. 40% they did not want to know, and 5% were kind of undecided about it. As far as the caregivers, in fact, most of the caregivers wanted to know. 75%. 23% they said no, and 2% undecided. Does giving the prognosis result in loss of hope? This is a very important topic. Well, studies have shown that giving prognostic information to patients does not cause hopelessness. Patients want honesty from their physicians. False optimism can lead patients to choose interventions that would not otherwise chosen if they have a realistic prognosis. Patients do not want over optimistic nor pessimistic presentations of their prognosis. We're going to define some terms here will help us out during our presentation. What's the difference between life-threatening, limiting, and terminal illnesses? Life-threatening is a potentially but not necessarily fatal, like severe infection, major trauma, MVA. In these situations, patients might go to the brink of death and then saved by the medical care, and they might return back to normal quality of life. Life-limiting illnesses are incurable, progressive illnesses that's leading to eventual death, like end-stage congestive heart failure, end-stage COPD, Alzheimer, and so forth, and advanced cancer. Medical treatments probably will lead to no cure, may prolong or improve the quality of life. Terminal illnesses are life-limiting illnesses with death anticipated within months, limited options, if any, to prolong life. This is basically the trajectories of how people die in adults. It might be sudden. It might be very gradual, like cancer. The upper right part here, cancer, they decline very slowly, and then all of a sudden they drop. And you see it all the time, in your hospitals, where the family will tell you he was just walking around yesterday and he was doing very well, and then all of a sudden, he started to decline. Then you have these organ failure, like heart failure, lung failure. In this situation, patients will drop gradually, and then there will be dips in between. And then the last one is like dementia, where the patient dwindles at a low functional status, from the get-go, and they go, slowly down. Pediatric, I know we're not doing pediatric here, but it's always good to make a comparison. In pediatric, you have the sudden unexpected death. Then you have the death from potential curable disease like brain cancer, and this is the commonest form that we see, or from a progressive condition like muscular dystrophy, or sometimes congenital anomaly. Components of prognosis: foreseeing and foretelling. Foreseeing is estimating the prognosis, and this could be done clinically and through actuarial estimation of survival, or in other words, calculated, estimation of survival. Foretelling is the discussing of the prognosis, which basically means the delivery of the prognostic information and the longitudinal process of communication. The shortcomings of clinical predictions. Unfortunately, physicians tend to overestimate the patient's survival by a factor of between 3 and 5. And in fact, they are more accurate at very short-term prognosis, not on the long-term prognosis. Also, the length of the doctor-patient relationships increases the odds of making more errors, because there's a kind of a bond between you and the patient, and you really don't want to deliver him, the bad news by yourself. So there was a couple of studies that have shown that medical physicians are basically 63% optimistic, 20% accurate, and 17% pessimistic. While palliative care physicians in another study showed that they are only 26.8% optimistic, 57.6% accurate, and 15.6% pessimistic, which actually tells you that palliative physicians do a better job in prognostication. And most of the other medical physicians, they are more optimistic. Okay, clinical prediction of survival. So clinical prediction of survival could be done through 3 approaches: temporal approach, surprise question, and probabilistic approach. Temporal approach is basically how long will this patient live? Overestimated survival is well established, as we mentioned, 3 to 5 folds. The surprise question is basically, would I be surprised if this patient died in a specific time frame? So this is most of the physicians like to use this approach because it's easier to utilize, and it's like yes or no question and answer. Probabilistic approach is what is the probability of survival of this patient in a specific time frame. By limiting the time frame of prediction, it outperforms the temporal approach. So the probabilistic approach is considered better than the temporal approach. But the one that's mostly used is the surprise question. The task force recommendations is basically the recommendations regarding the prognostic evaluation of patients. And as you can see, there are a number of predictors. 4 of them are clinical, like debility, which is functional status; dysphagia, anorexia, cachexia, which is the oral intake; delirium, or the cognitive function; and dyspnea. So we call them the 4 Ds. And also there are four labs that's very important in prognostication. There are much more than this, of course, but these are the basic ones that you need to at least start with, like leukocytosis, lymphocytopenia, the high C-reactive protein, which reflects the inflammation, and low serum albumin, which reflects the nutrition. We're going to talk about some of these actuarial indices that we talked about. We'll start with the Glasgow Prognostic Score, or GPS. And this one depends on CRP and serum albumin. Guys, this one was initially developed for non-small cell carcinoma. And it's a screening test. This is not something that you do later on at end of life. No, this is something you do early on. And it's pretty simple. And it relies on two parameters only, which is the CRP and the albumin. Of course, as you know, as the CRP goes up, your albumin would go down because inflammation suppresses the liver from producing albumin. Another score is called the palliative prognostic score, or the PAP. Okay, and with the PAP, there've been added two lab work. One of them is the total white blood count, and the other one is the lymphocytic count. And this one is good for people that are doing research. Okay, this will be a very good index. And as you see, it predicts the 30-day survival. So a total score from 0 to 5.5 is the 30-day survival is 70%, while a score of 11 to 17.5 is less than 30%. Another score called the PPI, or Palliative Prognostic Index. With this one, beside the oral intake and the dyspnea and the delirium, and in fact, there's also is added to the score. And this one predicts the 6-week survival. As you can see, from 0 to 290 days, 2 to 461 days, and above 4, score above 4 is only 12 days. And the total here is up to 15. So this score is from 0 to 15. We don't use it that much, but it's there. I mean, maybe at one point you want to study it or something, compare it to other indices. And then you have the ECOG. I'm sure all of you know the ECOG. The ECOG is one used by oncologists. So you really need to know it, because this is your a way to connect with the oncologist, is to explain to them what is the ECOG of the patient and so forth. In the ECOG, 5 is the worst. 5 is dead. Okay, so 0 is the best performance. It's the fully active, able to carry on all pre-disease performance without restriction. This is opposite to most of the other, indices that we're talking about. Another one is called the Karnofsky scale, which is an old scale that's been replaced by the PPS. And this is a comparison between the Karnofsky and the Zubrin. Zubrin is the ECOG. Okay. So again, this shows you, like here, the very sick patient is low, is 10. Okay, here it's it's opposite in the Zubrid scale or the ECOG scale. Just, it's important to understand it. So most of the time, patients that go to hospice have a Karnofsky less than 30%. And this one is the PPS. This one, I would say, replace the Karnofsky because it's more comprehensive. But it's basically an extension to the Karnofsky scale. All of these scales actually are performance scales. In other words, it depicts the function status of the patient. Again, prognosis, PPS, 50%, 76 days, 40%, predicted survival is 39 days, 10%, basically 3 days. So when I see PPS of like, 10%, this patient usually have, hours to days. However, this could be an acute episode. So if it's an acute event and you're trying to, fix it, that's fine. You cannot say this is, it's going to be 3 days. But if it's something well established, probably this patient will not have more than 3 days. All right, we'll talk about cancer. There are certain cancer syndromes that are well known to have very short survival, time, like malignant hypercalcemia, except in breast cancer or myeloma. You can say the patient probably has less than 2 months. Malignant pericardial effusion, also less than 2 months. Carcinomatous meningitis, from 2 to 3 months. Multiple brain metastases, without radiation 1 to 2 months, with radiation 3 to 6 months. And then other stuff like malignant ascites, pleural effusion, or malignant bowel obstruction. All of these are less than 6 months. And these are basically the hospice eligibility criteria. By the way, guys, these criteria are put by a society called the National Hospice and Palliative Care Organization. And you can actually access their website and you'll find these eligibility criteria and everything. Of course, it changes, every once in a while, but like these have been there forever, since the 90s. But I know that recently they made some modifications. So, these are the criteria for hospice eligibility in cancer patients. We'll jump into another important topic, which is dementia. As you guys know, dementia is not only one type. We have different types. We have Alzheimer, which constitutes around 62%, vascular 17%, mixed dementia 10%, dementia with Lewy body 4%, frontotemporal dementia 2%, Parkinson disease, and then you have other rarer conditions such as Creutzfeldt-Jakob disease and depression and multiple sclerosis. By definition, dementia is a chronic decline in memory and in at least one other area of cognitive function, sufficient to affect your daily life. And as a geriatrician, I'm sure this is basically, something that you're very well, accustomed to. The median survival after the initial diagnosis of dementia ranges from 8.3 years at the age of 65 and 3.4 years at the age of 90. Lewy body and frontotemporal dementias have earlier onset and progress at a faster rate than Alzheimer's. We use something called the FAST scale for, estimating the prognosis, in dementia patients. Basically, if the patient is 7 or more, he's hospice eligible. Okay, so usually I remember it this way: if I see a patient that's having urinary incontinence, fecal incontinence, and his speech is limited to less than 6 words, then probably this patient is hospice eligible. Again, according to the National Hospice and Palliative Care Organization, hospice eligibility for dementia is basically FAST stage 7. One of the following complications: aspiration pneumonia, upper urinary tract infection. Be careful about this. So this is like pyelonephritis, This is not like the regular, urinary bladder infection that we see. Sepsis, stage 3 or 4 pressure ulcers, weight loss more than 10% in the last 6 months, and albumin less than 2.5 gram per deciliter. Okay, then we'll talk about stroke. In stroke, we have ischemic stroke and we have hemorrhagic stroke. Hemorrhagic stroke is, around 14%, and ischemic stroke usually around, 86%. Okay, hemorrhagic stroke has a worse prognosis than ischemic stroke, as shown here by a Danish study that showed the 5-year survival rates, in hemorrhagic versus ischemic strokes. The hospice eligibility, again, in stroke, poor functional status, like a PPS of 40% or less. Again, inability to maintain hydration and caloric intake, like weight loss more than 10% or albumin less than 2.5. Current history of pulmonary aspiration without effective response to speech language pathology interventions. And then you have supporting documentation. And this supporting documentation, and this is very important for everyone, should be done only on the 3rd day. You have to wait till the 3rd day. So you'll see stuff like coma, abnormal motor stem response, absent verbal response, myoclonus, okay, beyond 3 days, all right? Absent withdrawal response and high serum creatinine above 1.5. All of this following the 3rd day of coma. Another important disease, it's more prevalent in the Caucasians. It's called the ALS, or amyotrophic lateral sclerosis. Sometimes they call it the Lou Gehrig disease because of the famous baseball player Lou Gehrig. And it affected also a very famous physicist called Stephen Hawking from UK. This guy survived for a long time, really, after being diagnosed. Because as you see, the median survival is only, after being diagnosed, is only 3 to 5 years. Only 10% can live 10 years or more. And then you have prognostic factors such as age, site of onset. So if it starts in the bulbar, this is worse than, the periphery. Symptom duration, and then we have a prognostic scale called the ALS FRS revised. And then the fourth, vital capacity, which is a very important predictor, uh, less than 60% predicted. So a patient, if you have a patient with ALS, what will be the most important prognostic factor? It is the forced vital capacity. This is just for the sake of the exam here. And this is basically the prognostic scale for ALS. The neurologists love the scale. They use it all the time to evaluate their ALS patients. So if you want to communicate with them about these folks, you need to understand the scale. And basically, the maximum score is 48. Nine items here are basically, related to their functional status, and then three items related to their breathing, like orthopnea, dyspnea, and use of mechanical ventilation. COPD patients. This is a very common problem. It's the sixth leading cause of death in high-income countries and is actually increasing in incidence, okay, versus other clinical diseases here. Now, with COPD, we use a different type of scale called the Booty scale. And the most important factor in this scale is the FEV1. So remember these, because these are kind of the questions that you might get in your exams. FEV1 for COPD patients. And we mentioned the forced vital capacity for ALS, which is a neurologic disease. And this is basically Booty index, predicting survival in 12 months, 24 months, and 52 months. And this is basically the Modified Medical Research Council dyspnea scale, because it's part of the Booty index as well. Okay, hospice eligibility for COPD, severe chronic disease, documented by 1 and 2 and 3. Patient has all of the following: disabling dyspnea at rest, and 2 is basically progression of the disease, evidenced by repeated office visits or ED visits. And number 3 is documentation of hypoxemia, PO2 of less than 55, or oxygen saturation less than 88%, or hypercapnia evidenced by a PCO2 of 50 millimeter mercury. I want to say something, guys, important here for these, tables. I don't want you to really, try to memorize them hard. Try to understand them. You should have them on your iPhone, your mobile, and whenever you see a case, just open it up. I mean, this is not something you want to try to memorize each item. You will never memorize them all. But let us say you have a COPD case. Open up your mobile and look it up, and that's it. And there's an app, by the way, in the that you can upload in your mobile. All right, congestive heart failure. Basically, we have two types. We have systolic dysfunction. We have diastolic dysfunction. Basic information. The prevalence of CHF is 1 to 2% in developed countries, although this figure is greatly influenced by age. Heart failure is relatively uncommon in those under 45 years of age, but frequently observed in those above 85. And basically, we have three scales. One of them is the American College of Cardiology slash American Heart Association and the New York Heart Association functional classes. With the one on the left here, you cannot, it's not reversible. So if you go from A to B, you're not going to go back to A. While in the New York Heart Association, you can, go to, let's say, stage 3, and then you go back to stage 2, depending on your treatment. That's why most people like to combine both of them. Another calculator that they use a lot in the United States, uh, the cardiology clinics right now in the United States, they have a special clinic for heart failure only. I mean, a full-time practicing cardiologist, all what he does is basically congestive heart failure. So they use this scale, the Seattle Heart Failure Model Calculator. They fill up this information and it gives them the prognostication at 1 year, 2 year, and 5 year. I mean, we hope, one of these days we do this in insurance as well. And then again, just to give you an idea about the New York Heart Association, if you're 1, you have a 7% mortality rate. If you're 4, you have 52% mortality rate. The hospice eligibility criteria for the CHF is basically New York Heart Association Stage 4 or ACC AHA Class D. In both, you have significant symptoms at rest and inability to carry out even minimal physical activity without dyspnea or angina. Patient is optimally treated. Patient has angina pectoris at rest, and then you have supporting documentation such as ejection fraction less than 20%. The functional benefits of advanced therapies, we found that stuff like, doing a defibrillator or the AICD, had improved, this prognosis of these folks. And as you can see, it can improve the 6-minute walking distance, improve the quality of life, decrease hospitalization, decrease the New York Heart Association functional classification, and reduce the sudden death. As you can see here, the functional status versus time, with the right supportive program, you can kind of reverse the patient back to earlier stages. So this makes it more difficult to estimate the prognosis in patients with congestive heart failure, because nowadays we have these, very sophisticated, techniques that can improve their functional status. Okay, we'll talk about end-stage liver disease, and I want to say we have two, classifications you need to know about. The Child-Pugh criteria, which was developed in the 60s, and then you have the model for end-stage liver disease, or the MELD score. The Child-Pugh was initially, started for prognosticating patients that will get the port 2 venous shunt. I remember, back my residency, they used to do these major surgeries you know,